Hello, my name is Vlad. I'm a resident. This is part 2 for pharmacology review for ITE. At neuromuscular junction, what is mechanism of termination of blockade? Well, I hope you're saying movement of acetylcholine away from the site of action. Acetylcholine moves away from the site of action, that is the termination of blockade. Contrast that essentially to acetylcholine degradation, which is not mechanism of action of termination of blockade. Make sure to know that. Next question. What is mechanism of action cis-etricurium at neuromuscular junction? It's autodegradation by Hoffman elimination. Mechanism of action of cis-etricurium of neuromuscular junction is autodegradation by Hoffman elimination. What coagulation factor does PCC contain? Well, I hope you're saying that PCC contains factor 2, factor 9, and factor 10. 2, 9, and 10. What is PCC used to treat? Well, it's 3 diseases: hemophilia B, factor 10 deficiency, and overcoagulation with warfarin. It is hemophilia B, factor 10 deficiency, and overcoagulation with warfarin. What is the contraindication to PCC? Well, I hope you're saying DIC, disseminated intravascular coagulation. Do you use FFP or PCC or recombinant factor 7 for reversal of anticoagulation? I hope you're saying PCC. Typically we use PCC to reverse anticoagulation. Unless it's warfarin. Then we use FFP. Does spironolactone cause edema? No, spironolactone does not cause edema. Does spironolactone cause hyponatremia? Yes. Spironolactone does cause low sodium and impotence. Hydrochlorothiazide causes hyper or hypokalemia. Well, I hope you're saying hypokalemia. Loop and thiazide diuretics cause hypokalemia. Is clonidine or dexmedetomidine more sensitive for alpha-2 receptor? Dexmedetomidine is more selective. What receptor does epinephrine use? It uses a mixed alpha and beta agonist. It is a mixed alpha and beta agonist. What receptors does phenylephrine use? Phenylephrine is an alpha-1 agonist. It is an alpha-1 agonist. How does lithium interact with neuromuscular depolarizing agents? Well, I hope you're saying that it potentiates paralysis. Lithium potentiates paralysis. What is the first mechanism of action that lithium potentiates neuromuscular depolarizing agents? Well, it activates potassium channels in prejunctional neurons. It activates potassium channels in prejunctional neurons. This interferes with transmission of action potential. What is the second mechanism of action? Well, I hope you're saying lithium's second mechanism of action to potentiate neuromuscular depolarizing agent is to activate potassium channels on postsynaptic myocytes, inhibiting muscle contraction. Lithium activates potassium channels on postsynaptic myocytes, inhibiting muscle contraction. So if the patient is on lithium, what is your next step in management for neuromuscular blockade? You reduce the dose. Reduce the dose. What is mechanism of action of Clostridium botulinum toxin? It cleaves snare protein. C. botulinum cleaves snare protein. What is mechanism of action of snare protein? Well, normally snare proteins allow acetylcholine vesicles in prejunctional nerve terminal to fuse with the membrane. Once again, snares allow acetylcholine vesicles in prejunctional nerve terminal to fuse with the membrane in order to be secreted. Iron impairs absorption of what drugs? Well, I hope you're saying carbidopa and levodopa. It binds catechol-based drugs. Iron binds carbidopa and levodopa, binding catechol-based drugs. Iron impairs pharmacokinetics of carbidopa and levodopa. How? Well, I hope you're saying it impairs absorption. Iron impairs with pharmacokinetics by impairing absorption. Cholestyramine impairs absorption of what drugs? Well, I hope you're saying that cholestyramine inhibits absorption of warfarin, aspirin, phenytoin, and furosemide. Cholestyramine inhibits absorption of warfarin, aspirin, phenytoin, and furosemide. Dexamethasone precipitates with which drugs? Dexamethasone precipitates with which drugs? Well, I hope you're saying ondansetron. It precipitates with ondansetron. What is the mechanism of action that dexamethasone precipitates with ondansetron? Well, I hope you're saying that it's the benzyl alcohol preservative which precipitates with dexamethasone. Benzyl alcohol preservative or ondansetron benzyl alcohol preservative in dexamethasone precipitates with ondansetron. Benzyl alcohol preservative is ondansetron in dexamethasone precipitates with ondansetron. Diclofenac does what to warfarin? It displaces it from aspirin. Diclofenac displaces it from aspirin. Hence, you will have increase in INR. When comparing phos-propofol to propofol, what is adverse reaction that phos-propofol have? It has increased paresthesias. Unlike propofol, does phos-propofol paresthesias are at the site of the ejection? No. The phos-propofol paresthesias are typically at another location like chest, ears, nose, and the buttocks. Once again, unlike propofol, which the paresthesia is at the site of injection, phos-propofol's paresthesias are at chest, ears, nose, and buttocks. Will pretreatment with local anesthetic, NSAID, or opioid decrease paresthesia with phos-propofol? Well, I hope you're saying no. Phos-propofol's paresthesias do not get reduced with anesthetics and sedative opioids. Bacterial inoculation with phos-propofol is less than propofol because there is no lipid bilayer. Bacterial inoculation with phos-propofol is typically less than propofol because there is no lipid bilayer. What is another common side effect of phos-propofol? Well, I hope you're saying pruritus that often occurs at the genitals. It is pruritus that often occurs at the genitals. Why is incidence of hypertension, respiratory depression, and apnea with phos-propofol lower than propofol? Once again, why is the incidence of hypertension, respiratory depression, and apnea lower with phos-propofol than propofol? It is because it has a slower onset of action. Phos-propofol has a slower onset of action at 4 to 10 minutes. What is phos-propofol metabolized to? It is metabolized to propofol via endothelial and hepatic alkaline phosphatases. Phos-propofol is metabolized to propofol via endothelial and hepatic alkaline phosphatases. Alright, so this next segment we're going to go over second messengers for different receptors. So we're going to talk about alphas and betas. So for adrenergic receptors, you need to know that all of them are G protein subunits. Okay, the alpha 1, alpha 2, beta 1, and beta 2, they're all G protein subunits. And they all use second messengers. And then we're going to briefly discuss locations of receptors and its actions. So alpha 1, what type of a G protein subunit is it? Well, I hope you're saying it's a GQ. It is a GQ G protein subunit. Alpha 1, what type of a second messenger cascade does it use? Well, I hope you're saying that it uses two. Alpha 1 increases IP3, which will in turn cause increase in calcium. The first pathway is increasing IP3, which will in turn increase calcium. The second mechanism of second messenger for alpha 1 is increase in DAG, which will increase the PKC. The second mechanism leads to increase in DAG, which will lead to increase in PKC. What is alpha 1 locations of receptors and their actions? Well, the general location for alpha 1 is in smooth muscles. Okay, it is in smooth muscles. Blood vessels, typically vasoconstriction. Blood vessel function is vasoconstriction. The second function of alpha 1 is in bladder neck, which causes sphincter contraction. In bladder neck, alpha 1 causes sphincter contraction. In gastrointestinal tract, what does alpha 1 cause? Well, I hope you're also saying sphincter contraction. Alpha 1 in gastrointestinal tract causes sphincter contraction. What is alpha 1 function in the iris dilator muscle? Well, it causes mydriasis, or dilation of the iris. Alpha 1 causes iris dilator muscle, causing mydriasis. Alright, the next G protein subunit is going to be alpha 2, which is a GI protein. GI protein for inhibitory. So, what is the second messenger cascade for alpha 2? Well, I hope you're saying cyclic AMP decreases, causing a decrease in calcium. Cyclic AMP decreases, which causes decrease in calcium. What are the locations of receptors and their actions? Well, there are a total of 4. The first one is in ciliary body. Alpha 2 in ciliary body decreases aqueous humor secretion. Alpha 2 in ciliary body causes decreased aqueous humor secretion. Alpha 2 is also present in the pancreas, and it causes decreased insulin secretion. Alpha 2 is also present in the pancreas, and it causes decreased insulin secretion. Now, what is the role of alpha 2 in platelets? Well, I hope you're saying alpha 2 induces platelet aggregation. Alpha 2 causes platelet aggregation. What is the role of alpha 2 in prejunctional nerve? Well, I hope you're saying decreased norepinephrine release. In prejunctional nerves, alpha 2 channel decreases norepinephrine release. Next channel. So we're talking about beta 1. Its G protein subunit is GS. GS. What is the second messenger for beta 1 subunit? Well, I hope you're saying it increases cyclic AMP, which in turn increases calcium intracellularly. It increases cyclic AMP, which in turn increases intracellular calcium. What are the two areas where beta 1 acts? Well, of course, the first one is the heart. I hope you're saying it increases heart rate, conduction velocity, and force of contraction, or contractility. Heart rate increases conduction velocity and force of contraction, or contractility. Now, where is the second area where beta 1 channels work? Well, I hope you're saying kidney. It increases renin release. Reninol release is increased where beta 1 channel. Alright, continuing along. What is the beta 2 G protein subunit? Well, I hope you're saying GS. GS. What is the second messenger cascade? It's actually the same as beta 1. It's increase in cyclic AMP, but decrease in calcium, intracellular calcium. It causes increase in cyclic AMP, but decrease in intracellular calcium. Now, where are the locations for beta 2? Well, there are a few. There are a total of 7. We're going to go through 7 of them. Beta 2 acts on the liver. Beta 2 increases glycogenolysis. Beta 2 acts on the liver, causing increase in glycogenolysis. Beta 2 also acts on pancreas. It increases insulin secretion. Beta 2 acts on pancreas. It increases insulin secretion. Beta 2 also acts on smooth muscle, causing acting on smooth muscles. Where in there's 4 specific areas where it acts on the smooth muscles. In the smooth muscle of bladder, blood vessels, bronchioles, and uterus. So beta 2 in the smooth muscle of bladder causes relaxation. Beta 2 in the smooth muscle of the bladder causes bladder relaxation. Beta 2 in the blood vessels causes vasodilation. Beta 2 channel in blood vessels causes vasodilation. Beta 2 channel in the bronchioles causes bronchodilation. Beta 2 channel in bronchioles causes bronchodilation. And last but not least, beta 2 in the smooth muscle of uterus causes uterine relaxation. Beta 2 in the smooth muscle of uterus causes uterine relaxation. Continuing along, so we're done with the channels. We're going to go into asking rapid fire questions. So vecuronium is dependent on what type of metabolism? Well, I hope you're saying hepatic and also excreted via urine into bile. Vecuronium is dependent on what type of metabolism? Well, I hope you're saying hepatic and then urine and bile excretion. Vecuronium is dependent on what type of metabolism? Well, I hope you're saying renal metabolism. Why do older patients have decrease in mecavurium metabolism? Because they have decrease in pseudocholinesterase. Older patients have decrease in mecavurium metabolism because they have decreased pseudocholinesterase. Administering midazolam in 3rd trimester is associated with what syndrome? I hope you're saying floppy baby syndrome. Administering midazolam in 3rd trimester is associated with floppy baby syndrome. What is the floppy baby syndrome? Well, I hope you're saying laxity of muscles when the baby is laying supine. There's laxity of muscles when the baby is laying supine. Can midazolam be given during emergency cesarean delivery? No, it cannot. What medications are considered safe in pregnancy other than propofol? Well, I hope you're saying ketamine, etomidate, and neuromuscular blockers. In pregnancy, safe medications are propofol, ketamine, etomidate, and neuromuscular blockers. When rapid blood loss, when in pregnancy you have rapid blood loss due to trauma, what do you give? You give etomidate. What effects does inhaled anesthetics have on the fetus? Well, I hope you're saying that inhaled anesthetics cause bradycardia, heart rate variability that may require respiratory support. Inhaled anesthetics in the fetus cause bradycardia, heart rate variability that may require respiratory support. Of note, inhaled anesthetics are considered halogenated agents. They're just halogenated agents that are volatile anesthetics. What are halogenated agents' effect on uterus? Well, I hope you're saying that it causes uterine relaxation associated with increased blood loss. Halogenated agents, like volatile anesthetics, relax the uterus associated with increased blood loss. What effects do opioids cause in the fetus? Well, I hope you're saying that they cause bradycardia and respiratory depression. Opioids cause bradycardia and respiratory depression in the fetus. What agents prolong non-depolarizing blockade? So, there's several. We're going to talk about prolonging and then shortening of non-depolarizing blockade. So, prolonging non-depolarizing blockade. There is acute use of anticonvulsants such as phenytoin and carbamazepine. Acute use of anticonvulsants such as phenytoin or carbamazepine. Antibiotics that prolong non-depolarizing blockade. streptomycin, clindamycin, tetracycline, and aminoglycosides. Antibiotics such as streptomycin, clindamycin, tetracyclines, and aminoglycosides. Prolonging non-depolarizing blockade are antiarrhythmics such as calcium channel blockers. Calcium channel blockers are an example of antiarrhythmics that prolong non-depolarizing blockade, but it's all antiarrhythmics in general. Dantrolene, ketamine, and local anesthetics in high doses prolong non-depolarizing blockade. Dantrolene, ketamine, and local anesthetics in very high doses prolong non-depolarizing blockade. Lithium, magnesium, and volatile anesthetics also prolong non-depolarizing blockade. Lithium, magnesium, and volatile anesthetics also prolong non-depolarizing blockade. What shortens non-depolarizing blockade? Well, I hope you're saying chronic use of anticonvulsants of phenytoin and carbamazepine. Chronic use of anticonvulsants. The other shortening on non-depolarizing blockade are cholinesterase inhibitors, such as neostigmine. What is fat blood partition coefficient? I hope you're saying it is affinity of fat for blood like blood gas coefficient, but with fat, larger coefficient means fat has greater affinity. So fat blood partition coefficient is how much affinity fat has for medication rather than blood. What happens if fat blood coefficient gets larger? There's slower induction through decreased FA to FI ratio. When fat blood coefficient gets larger, there's slower induction through the decreased FA to FI ratio. What are the factors that increase FA to FI? Well, I hope you're saying low blood gas coefficient, low cardiac output, high minute ventilation, and low pressure arterial minus pressure venous. Factors that increase FA to FI are low blood gas coefficient, low cardiac output, high minute ventilation, and low pure arterial minus pressure venous of the gas. What are part of four-compartment model? What are the parts of the four-compartment model? Well, I hope you're saying the alveoli, which is central compartment, vessel-rich group, muscle group, and fat group. The alveoli, central compartment, which has goes into vessel-rich group, then goes to muscle group, and then the fat group. What are the key characteristics of the four-compartment system? Well, I hope you're saying intercompartment rate constant and effective volume. I hope you're saying intercompartment rate constant and effective volume are key characteristics of the four-compartment model. As a result of increased cardiac output, what leads to slow induction? Well, I hope you're saying as intercompartment constant increases, there's more exposure to a large fat group, leading to larger fat blood coefficient, and hence lower FA to FI rise. Once again, as intercompartment constant increases, there's more exposure to a large fat group, leading to large fat to blood coefficient, leading to lower FA to FI rise. Metabolism of neuromuscular blockers. How is acetylcholine metabolized? Well, I hope you're saying plasma cholinesterases. For rocuronium, how is rocuronium metabolized? Well, I hope you're saying that it's 70% in liver and then also in bile and urine. It is metabolized mostly in 70% in liver, but also secreted in bile and urine. For vecuronium, how is vecuronium metabolized? Well, I hope you're saying 50% liver and then bile and urine. It is metabolized 50% in liver and then bile and urine. Cis-etricurium. How is cis-etricurium metabolized? Well, I hope you're saying Hoffman elimination. Should diuretics be taken the day of surgery for non-heart failure patients? No, they should not. What is an exception to taking diuretic on the day of surgery? if, for example, thiazide diuretic like chlorthalidone, hydrochlorothiazide are taken for hypertension, or if the patient has heart failure. The exception to taking a diuretic is if the patient has, treatment for hypertension or heart failure with drugs, thiazide diuretics such as chlorthalidone or hydrochlorothiazide. Why? Well, because of the large fluid shifts. So if they have symptoms of ascites, volume overload, and the minor procedures, these are typically can be continued for large fluid shifts. Should hypertension medications be continued before surgery? Yes. Hypertension medication should be continued before surgery. What is the exception? You should not be giving angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers. They should be discontinued 12 to 24 hours preoperatively. ACE inhibitors and angiotensin II receptor blockers should be discontinued 12 to 24 hours preoperatively. Should beta blockers be continued prior to surgery? Yes, they should be. What are cardiac side effects of sevoflurane, the volatile anesthetics? So sevoflurane increase heart rate, decrease in systemic vascular resistance, they decrease MAP, decrease heart contractility, have no effect on cardiac output, and there's prolongation of QT interval. The cardiac side effects, if you will, of sevoflurane and volatile anesthetics is increase in heart rate, decrease in systemic vascular resistance, decrease in MAP, decrease heart contractility, neutral cardiac output, and prolongation in QT interval. What happens when hyperbaric local anesthetic is injected into CSF? It flows with gravity. Hyperbaric local anesthetic will flow with gravity when injected into CSF. What happens with isobaric local anesthetic is injected into CSF? It stays at the level of the injection. Isobaric local anesthetics stay in the level of the injection. What happens when a hypobaric local anesthetic injected into CSF? Flows against gravity. It flows against gravity. What is baricity? Well, I hope you're saying ratio of two densities of local anesthetic to CSF. It's made hyperbaric by addition of dextrose. Baricity influences the dermatomal spread of local anesthetic. So once again, baricity is the ratio of two densities of local anesthetic to CSF, made hyperbaric by adding dextrose, and it influences the dermatological spread of local anesthetics. Is montelukast a leukotriene modifier? Yes. Montelukast is a leukotriene receptor antagonist. Montelukast is a leukotriene receptor antagonist. What is the mechanism of action of omalizumab? What is the mechanism of action of omalizumab? I hope you're saying it's an IgG antibody that binds IgE. Montelukast is a recombinant antibody that binds IgE. Netochromyl mechanism of action. What is the mechanism of action of netochromyl? Well, I hope you're saying it's a mast cell stabilizer inhaler. It's like a treatment way down the pathway, but it's a chromalin derivative. Netochromyl is a mast cell stabilizer inhaler. It is a chromalin derivative. How does nitrous oxide lead to megaloblastic anemia? Well, I hope you're saying it inhibits irreversibly vitamin B12 cobalamin, a necessary cofactor for methionine synthase. So essentially inhibiting DNA synthesis. It inhibits irreversibly vitamin B12, which is cobalamin, a necessary cofactor for methionine synthase. What process gets inhibited? DNA synthesis via homocysteine to methionine conversion. DNA synthesis gets inhibited via conversion of homocysteine to methionine conversion. What are other side effects of chronic nitrous oxide exposure? Well, I hope you're saying myelopathy, neuropathy, and encephalopathy. Other than megaloblastic anemia, there is neuropathy, myelopathy, and encephalopathy. What happens when a mannitol is given acutely? Example, 20 minutes. There's increase in plasma volume, diluting hemoglobin, and increase in cardiac output and blood pressure. When mannitol is given acutely, there's increase in plasma volume, diluting the hemoglobin, and increase in cardiac output and blood pressure. What monitor metric can go up after administration of mannitol? I hope you're saying pulmonary capillary wedge pressure can go up after administration of mannitol. Pulmonary capillary wedge pressure can go up. Cyclosporine, this is a random one, is metabolized by what? Cyclosporine is metabolized by CYP P4050 system. Alright, so the next portion we're going to talk about herbal supplements, their pharmacological effects, and perioperative concerns. So once again, we're going to go over herbal supplements now. So we're going to talk about a herbal supplement, its pharmacological effect, and perioperative concerns. So echinacea, what are the pharmacological effects of echinacea? I hope you're saying it's activity of cell-mediated immunity. Its activation of cell-mediated immunity is concerned with echinacea. What are the perioperative concerns? Well, there are a total of 3. There's the allergic reactions, decreases effectiveness of immunosuppressants, and long-term use may cause immunosuppression. Echinacea's perioperative concerns are allergic reaction, decreased effectiveness of immunosuppressants, and long-term use may cause immunosuppression. Alright, for herbal supplement of garlic, what is its pharmacological effect? Well, it is an antiplatelet and increases fibrinolysis. Garlic has antiplatelet use and increase in fibrinolysis. Perioperative concerns is that it may increase risk of bleeding. Next herbal supplement is ginger. What are the pharmacological effects of ginger? Well, I hope you're saying it's an antiemetic and an antiplatelet. Ginger is an antiemetic and an antiplatelet. It may increase risk of bleeding. Herbal supplement ginkgo. What is its pharmacological effect? Ginkgo inhibits platelet activating factor. It inhibits platelet activating factor. It also may increase risk of bleeding. Ginkgo may increase risk of bleeding as its perioperative concern. What is the herbal supplement ginseng? What is its pharmacological effects? Well, I hope you're saying lowers blood glucose, and it's an antiplatelet. Ginseng lowers blood glucose and is an antiplatelet. What are ginseng's perioperative concerns? Well, I hope you're saying hypoglycemia. It may increase risk of bleeding. It may decrease anticoagulation by warfarin. Ginseng's 3 perioperative concerns are hypoglycemia, increase risk of bleeding, and decrease anticoagulation by warfarin. Alright, next herbal supplement is green tea. What are pharmacological effects? Well, I hope you're saying it's an antiplatelet, inhibits thromboxane A2 formation. It is an antiplatelet and inhibits thromboxane A2 formation. Its for perioperative concerns is it may increase risk of bleeding. It may decrease anticoagulation by warfarin. It may increase risk of bleeding. It may decrease anticoagulation by warfarin. Next herbal supplement is kava. What are its pharmacological effects? Well, I hope you're saying sedation and anxiolysis. Kava has sedation and anxiolysis. Its perioperative concerns is that it may increase sedative effects of anesthetics. Kava may increase sedative effects of anesthetics as its perioperative concern. Alright, next herbal supplement is a saw palmetto. Saw palmetto's pharmacological effect is inhibition of 5-alpha reductase and cyclooxygenase. Inhibition of 5-alpha reductase and cyclooxygenase. Its perioperative concern is may increase risk of bleeding. Saw palmetto may increase the risk of bleeding as its perioperative concern. Next herbal supplement is St. John's wort. Its pharmacological effect is inhibition of neurotransmitter reuptake. Its pharmacological effect is inhibition of neurotransmitter reuptake. It has three perioperative concerns. St. wort induces cytochrome P450 enzymes, decreases digoxin level, and there is delayed emergence. And once again, St. John's wort induces cytochrome P4050 enzymes, decreases digoxin levels, and there's delayed emergence. What does valerian cause? Its pharmacological effects are sedation. It has three perioperative concerns. So valerian causes sedation, and its perioperative concerns are increase the sedative effect of anesthetics, benzodiazepine-like acute withdrawal. It may increase anesthetic requirement with chronic use. So once again, valerian perioperative concerns is that it may increase the sedative effect of anesthetics. There's benzodiazepine-like acute withdrawal. It may increase anesthetic requirement with chronic use. Alright, so we're done with herbal supplements for ITE. Next up is the factors affecting MAC. So what are the four factors that increase MAC? Well, I hope you're saying drugs that increase central neurotransmitters, hyperthermia, hypernatremia, and chronic ethanol abuse, so chronic alcohol use. Factors that increase MAC are drugs that increase central neurotransmitters, hyperthermia, hypernatremia, and chronic alcohol abuse. What are the factors that decrease MAC? There's a total of 10 of them. Decrease MAC are drugs that decrease central neurotransmitters, older age, metabolic acidosis, hypoxia, hypothermia, hyponatremia, acute alcohol ingestion, lithium, pregnancy, and administration of other anesthetics. So the 10 factors that decrease MAC are drugs that decrease central neurotransmitters, older age, metabolic acidosis, hypoxemia, hypothermia, hyponatremia, acute ethanol ingestion, lithium, pregnancy, and administration of other anesthetics. According to new guidelines, MAC decreases by 6% after what age? I saw that it said 30. Tramadol advantage over the opioids. There is a tramadol advantage over other opioids that there's lower risk of respiratory depression, constipation, and lower potential for abuse. There's lower risk for respiratory depression, constipation, and lower potential for abuse. Which receptor does tramadol bind to? Tramadol only binds to mu receptor. It has weak affinity for it. There's no kappa or delta binding. Does tramadol have risk of respiratory depression? Lower risk of respiratory depression due to lower affinity of mu receptor. Tramadol has lower risk of respiratory depression because there is lower affinity for mu receptor. What is another mechanism of tramadol? Well, I hope you're saying limits serotonin and norepinephrine reuptake in the neurons. Serotonin is what thought to contribute to analgesic effect of tramadol. So another mechanism that tramadol uses is it limits serotonin and norepinephrine reuptake in the neurons, and serotonin is thought to contribute to its additional analgesic effect. What is the most common route of tramadol administration? Well, I hope you're saying orally. What are other routes that tramadol administered? There's a bunch. IV, IM, oral, rectal, sublingual. But oral is the most common. What is tramadol's bioavailability for allowing first-pass metabolism? Well, I hope you're saying it's 70%. Bioavailability of 70% after first-pass metabolism. What is tramadol's plasma elimination half-life? I hope you're saying 6 hours. Tramadol has half-life of 6 hours. How is tramadol metabolized and excreted? Well, I hope you're saying it's conjugated in the liver and excreted by kidneys and 1% in bile. It's conjugated in the liver and excreted by kidneys and 1% in bile. Does tramadol pass through placental barrier? Yes, tramadol passes through the placental barrier. Is tramadol secreted in breast milk? No, tramadol is not secreted in breast milk. Is is there risk of ileus with tramadol? There is lower risk of ileus, minor effect on transit time. It has a lower risk of ileus overall. Does tramadol have any clinical hemodynamic effects? No, tramadol does not have any clinical hemodynamic effects. What is delta receptor role in the opioids? Well, I hope you're saying that delta receptor is responsible for analgesia, antidepressant, and physical dependence. Delta receptor role in opioids acts on analgesia, antidepressant, and physical dependence. What is the kappa receptor role in opioids? Well, I hope you're saying analgesia, dysphoria, meiosis, and sedation. Kappa receptor is responsible for analgesia, dysphoria, meiosis, and sedation. How about mu receptor? What is the role of the mu receptor? Well, I hope you're saying analgesia, physical dependence, respiratory depression, meiosis, euphoria, and decreased GI motility. Mu receptor is responsible for analgesia, physical dependence, respiratory depression, meiosis, euphoria, and decreased GI motility. What is mechanism of action of opioids? Well, so this is a protein question. It binds G protein coupled receptor and inhibits the presynaptic release and postsynaptic response to excitatory neurotransmitters from nociceptive neurons. Through binding G protein coupled receptors, it inhibits presynaptic release and postsynaptic response to excitatory neurotransmitters from nociceptive neurons. Furthermore, acute opioid effects are mediated by inhibition of adenylyl and activation of phospholipase C. Acute opioid effects are mediated by inhibition of adenylyl and activation of phospholipase C. Opioid receptor activation inhibits the excitatory response from nociceptive neurons primarily through blocking release and response of excitatory neurotransmitters, such as acetylcholine and substance P. It inhibits excitatory neurotransmitter release, such as acetylcholine and substance P. What pathway does opioid inhibit? Well, I hope you're saying perihelical presynaptic transmission to dorsal horn nuclei. Although it can affect postsynaptic as well, but it's peripheral presynaptic transmission to dorsal horn nuclei. Peripheral presynaptic transmission to dorsal horn nuclei is the pathway. Do opioids cause amnesia? No, the opioids do not. What are some common opioid antagonists? Well, I hope you're saying nalbuphine, butorphanol, and pentazocine. Nalbuphine, butorphanol, and pentazocine are some common opioid agonist-antagonists. Again, they're agonist-antagonists. Nalbuphine, butorphanol, and pentazocine. What is ectothiopate? Ectothiopate is an anticholinesterase used to treat refractory glaucoma by causing meiosis. Ectothiopate is an anticholinesterase used to treat refractory glaucoma causing meiosis. Its ectothiopate's systemic absorption can cause up to 95% decrease in plasma butyrylcholinesterase function. So what effect does ectothiopate have on neuromuscular blockade? Ectothiopate inhibits pseudocholinesterase, thereby potentiating the effects of succinylcholine. It takes approximately 4 to 6 weeks for butyrylcholinesterase activity to return after ectothiopate is administered. Hence the potentiating effect of succinylcholine. What is timolol and its side effects? Well, I hope you're saying timolol is a non-selective beta-adrenergic blocking agent used topically for treatment of glaucoma. Timolol is a non-selective beta-adrenergic blocking agent used topically for treatment of glaucoma. Its absorption can lead to bronchospasm and bradycardia. What is betaxolol? Betaxolol is a selective beta-1 antagonist. Bitoxyl is a selective beta 1 antagonist that is relatively ocular specific with minimal systemic side effects. Is this statement about propofol true? The time to decrease in blood pressure is longer than time to hypnosis. Yes, propofol hypnosis onset time is 90 to 100 seconds and it lasts 5 to 10 minutes. So its hypnotic effect goes on faster than its decrease in blood pressure. How does propofol act on CYP3A4 system? Propofol inhibits CYP3A4 system. Okay, so now we're going to talk about some pressure volume loop questions and also tropies. So tropies like chronotropy, etc. So what is cardiac tropism? Tropism is the effect of outside stimulation has on the heart. Tropism is the effect of outside stimulation has on the heart. What is cardiac ionotropy? Cardiac ionotropy is another way for name contractility. Cardiac ionotropy is contractility. What is cardiac chronotropy? Cardiac chronotropy is heart rate. Heart rate. What is cardiac dromotropy? Dromotropy is speed or velocity or rate of conduction through the AV node. Dromotropy is the velocity, speed, or rate of conduction through the AV node. What is bathrotropic? What is bathrotropic? Bathrotropic is the change in excitability of resting membrane potential of the heart. How far it has to essentially go in order to hit fire on the threshold. So bathrotropic is that like electricity gradient to get to the threshold so it can go down or up. What is cardiac lucentropy? Cardiac lucentropy is increase in relaxation of myocardium during diastole. Lucentropy is relaxation of myocardium during diastole. All right. What effects does beta 1 adrenergic receptor result in? Well, I hope you're saying increase in ionotropy, chronotropy, dromotropy, and it would have decrease in lucentropy. Chronotropy is governed by what? The SA note. Chronotropy is governed by the SA note. What effect does adrenaline have on chronotropy? It increases it. It increases it. What effect does acetylcholine have on chronotropy? It decreases it. Decreases it. How is ionotropy governed? Well, I hope you're saying it's governed through intracellular calcium. Ionotropy is governed through intracellular calcium. What effect does digoxin have on ionotropy? I hope you're saying it increases ionotropy because it increases intracellular calcium. Digoxin increases ionotropy because it increases intracellular calcium. What effect do calcium channel blockers have on ionotropy? Well, I hope you're saying decreases ionotropy because there's a decrease in intracellular calcium. There is calcium channel blockers have decrease in ionotropy because there's a decrease in intracellular calcium. How is dromotropy governed? Well, I hope you're saying it's a speed of electricity through the AV node. Dromotropy is the speed of electricity through the AV node. How does adrenaline affect dromotropy? It increases dromotropy. How does digoxin on dromotropy? It decreases dromotropy. Decreases dromotropy. What effect does acetylcholine have on bathromotropy? Acetylcholine decreases it. It decreases the threshold excitability, so it has a longer way to go to fire off. What governs lucentropy? So lucentropy is governed by the amount of calcium. So the less calcium, the more the heart can relax. So the opposite of ionotropy. What effect does calcium accumulation in smooth muscles or blood vessels have? Well, I hope you're saying dilation of blood vessels. Accumulation of calcium in smooth muscles leads to dilation of blood vessels. What effect does milrinone have on peripheral vasculature? Milrinone causes smooth muscle vasodilation, slang term ionodilator, in pulmonary and peripheral vasculature. Milrinone causes smooth muscle vasodilation, slang term ionodilator, in pulmonary and peripheral vasculature. What is the effect does milrinone have on the heart? Well, I hope you're saying milrinone increases cardiac ionotropy, increasing cardiac contractility. Milrinone increases cardiac ionotropy, increasing cardiac contractility. What is the mechanism of action of milrinone on the heart? Well, I hope you're saying phosphodiesterase 3 inhibitor leads to increased cyclic AMP, which increases cardiac calcium, which increases contractility. So milrinone causes in the heart phosphodiesterase 3 inhibitor leads to increase in cyclic AMP, which leads to increase in calcium, which increases contractility. What is the mechanism of action of milrinone in the blood vessels? Smooth muscle. Well, increases phosphodiesterase 3 inhibitor. Phosphodiesterase 3 inhibitor leads to increase in cyclic AMP, which increases calcium, which causes vasodilation. Milrinone can also be used to treat pulmonary hypertension. Just a fun fact. This concludes pressure volume loop section. In older adults, what essentially contributes to high initial concentration of propofol compared to younger patients? Well, I hope you're saying decreased central compartment volume. In older adults, for high initial concentration of things like propofol compared to younger adults, there's decrease in central compartment volume. All right, to review briefly the coagulation pathway cascade, the extrinsic pathway are factors 7 only. Intrinsic factors are factors 12, 9, 11, 9, and 8. The common pathway are 10, 5, 2, 1, and 13, which binds 1 to form fibrin mesh. Fibrin mesh has to then bind to plasmin for fibrin to be degraded. So plasminogen is activated by TPA, which forms plasmin, which then acts on the fibrin mesh that was stabilized and leads to degradation product called D-dimer. And just briefly, because we're going to this topic next, TXA inhibits the tissue plasminogen activation factor, which typically activates plasminogen to form plasmin, so that we don't degrade the fibrin mesh. Alright, so now this is a perfect time. What is the mechanism of action of aminocaproic acid and tranexamic acid? Well, I hope you're saying inhibition of plasmin formation and fibrin degradation. There's inhibition of plasmin formation and fibrin degradation. How do they do this? Well, as a lysine analog, aminocaproic acid and tranexamic acid prevent formation of tertiary complexes between plasminogen, TPA, and fibrin. As a lysine residue essentially prevents formation of a complex between plasminogen, TPA, and fibrin. The lysine residue and plasminogen cannot bind lysine site on fibrin. What surgery is TXA specifically indicated for? Well, I hope you're saying cardiopulmonary bypass. Cardiopulmonary bypass. The mechanism of action is that cardiopulmonary bypass causes TPA release from endothelium. Cardiopulmonary bypass surgery causes TPA release from endothelium. What are the 5 neurotransmitters that mediate nausea and vomiting? Well, I hope you're saying histamine H1, 5-hydroxytryptamine HT3, neurokinin and substance P, muscarinic M1 receptor, and dopamine D2 receptor. So once again, it's histamine H1, 5-hydroxytryptamine HT3, neurokinin substance P, muscarinic M1, and dopamine D2. Aprepitant blocks sedation of which 3 molecules? Well, I hope you're saying it blocks substance P, neurokinin 1, and neurokinin 2, preventing activation of neurokinin receptor. So aprepitant blocks substance P, neurokinin 1, and neurokinin 2, preventing activation of neurokinin receptor. What drug has efficacious as ondansetron and antagonizes histamine? Well, I hope you're saying diphenhydramine. Diphenhydramine is just as efficacious as ondansetron that antagonizes histamine. What can be used as prophylaxis as post-operative nausea and vomiting is effective as using an antiemetics? I hope you're saying acupuncture. Acupuncture as a prophylaxis and post-operative nausea and vomiting is effective as using antiemetics. What is the mechanism of action of acupuncture for post-operative nausea and vomiting? Well, I hope you're saying targeting pericardium 6, aka P6. Targeting pericardium 6, aka P6. Where is pericardium 6 point located? Well, I hope you're saying few inches above the wrist on anterior surface of the arm between tendons of palmaris longus and flexor carpi radialis. It is tendons of palmaris longus and flexor carpi radialis on the anterior surface of the arm, few inches above the wrist. All right. So next portion, we're briefly going to talk about pharmacology, additive, and synergistic effect. Continuing along, drugs that act, additive, synergistic. So drugs that act by same mechanism of action to produce, for example, sedation if they were active alone. Drugs that act by same mechanism of action to produce, for example, sedation as if they were acting alone. That is called additive. What is an example of additive sedation? Well, if you have sevoflurane at 0.5 Mac and desflurane at 0.5 Mac, they cause the same effect as if the drug was alone, a concentration of Mac 1. Okay, so they're additive. Drugs that act by different mechanism of action produce, for example, sedation. It's greater than the sum of the effect size when either drug is given alone. That's called synergistic. So, essentially, what is the example of synergistic sedation? Well, it's like midazolam and dexmedetomidine. Midazolam and dexmedetomidine have synergistic properties. Another example is respiratory sedation of propofol and remifentanil. Drugs that act in infraadditive or antagonistic will have a lower effect than when a drug is given alone. So what is an example? It is ketamine and propofol are combined. And just so you know, the drug that typically causes additive or synergistic or infraadditive, depending on a drug combination, is ketamine. Ketamine is that drug that can act in all three ways. But just to overview once again, if you're giving same mechanism drugs, they're most likely going to be additive. If they're different mechanism drugs, most likely going to be synergistic. And then the antagonistic and infraadditive are the same thing. Antagonistic and infraadditive are the same thing. What drug typically cause essentially? So we talked about ketamine already. Do opioids have effect on BIS monitoring? No, opioids do not have effect on BIS monitoring. What patient risk factor has increased incidence of opioid-induced pruritus? Well, I hope you're saying pregnancy. Pregnancy increases the incidence of opioid-induced pruritus. Which route predisposes pregnant patients to pruritus? Well, I hope you're saying intrathecal or epidural route for opioids predisposes them to pruritus. What effect do lipophilic opioids have on duration of pruritus? They lower the duration. Lipophilic opioids have lowered the duration of pruritus. What effect do hydrophilic opioids have on duration of pruritus? Well, I hope you're saying longer duration. Hydrophobic opioids have longer duration for pruritus. What co-administration can decrease incidence of pruritus with opioids? Well, I hope you're saying local anesthetics. Co-administration that can decrease incidence of pruritus is local anesthetics. All right, we got some questions about ketamine. Ketamine is a highly soluble molecule. So essentially, is ketamine highly protein bound? No, it is not protein bound, different from many other IV anesthetics. Ketamine is not protein bound, which makes it different from many other IV anesthetics. Is ketamine a derivative of what molecule? I hope you're saying phenylcyclidine. What is the mechanism of action of ketamine? It is an NMDA receptor antagonist in the dorsal horn, producing intense analgesia and dissociative amnesia. NMDA receptor antagonist, ketamine, is an NMDA receptor antagonist in the dorsal horn, producing intense analgesia and dissociative amnesia. What an enantiomer composition of ketamine? So it has two. It has an S plus that is more potent, producing analgesia and shortened duration of action. There's an R minus enantiomer, which has greater effect for NMDA receptor. It has a greater effect on the NMDA receptor and longer duration. How much more potent are S plus only solutions? S plus solutions are approximately 3 to 4 times more potent. Ketamine is metabolized by what mechanism? Or I hope you're saying CYP3A4 and CYP2B6 pathway into neuroketamine and excreted renally. Ketamine is metabolized by CYP3A4 system and CYP2B6 pathway into norketamine and is excreted renally. How active is norketamine? It is approximately 1/3 physiological activity. It has 1/3 of physiological activity. What is half-life of ketamine? 2 to 3 hours. 2 to 3 hours. What routes can ketamine be administered? Almost every route. What is IV bioavailability of ketamine? I hope you're saying 90%. 90%. What about oral and rectally? 15% due to incomplete intestinal absorption. 15% orally or rectally. What are possible contraindications to ketamine? Well, I hope you're saying increased intracranial pressure with spontaneous ventilation, intracranial mass lesion with spontaneous ventilation, open eye injury or other ophthalmologic disorders, ischemic heart disease, vascular aneurysm, and psychiatric disease such as schizophrenia. So once again, contraindication to ketamine is increased intracranial pressure with spontaneous ventilation, intracranial mass lesion with spontaneous ventilation, open eye injury or other ophthalmologic disorders, so eye stuff, ischemic heart disease, vascular aneurysms. So ischemic heart disease is a sole agent, vascular aneurysm is a sole agent, and psychiatric disease such as schizophrenia. Of commercially produced carbon dioxide absorbers, which carbon dioxide absorber has the greatest potential to produce carbon monoxide? So soda lime has the highest concentration of the strong base, so hence soda lime has the greatest potential to produce carbon dioxide. However, the one that is no longer produced is called bear lime and has greater potential than soda lime to produce it, but soda lime is the one that we still use. What factors influence increased carbon monoxide production from carbon dioxide absorbers? There is several. So there is essentially 4. So the factors that increase carbon monoxide production from CO2 absorbers is there's decreased water concentration, so dry absorbent material, increased strong base concentration within the absorbent, increased concentration of volatile anesthetics, and chemical structure of the volatile anesthetic. So once again, you have dry absorbent, if you have increased strong base, increased concentration of volatile anesthetic, and the chemical structure of volatile anesthetic. Which volatile anesthetic gas has the greatest potential to produce carbon monoxide? Or I hope you're saying desflurane has the greatest, and isoflurane is after that. So desflurane and then followed by isoflurane. What is the mechanism of action then? Well, it's the halogenated anesthetic degradation. Does degradation of sevoflurane produce carbon monoxide? No, it does not. It produces carbon monoxide, but produces it does not produce carbon monoxide as a sevoflurane, but produces large amounts of heat, and it produces compound A. That essentially produces, and so sevoflurane produces compound A. Specifically on compound A, it has been shown in animals to cause tubular necrosis, but not in humans. It doesn't. We don't have evidence that compound A causes tubular necrosis in humans. What is the mechanism of action of propofol and barbiturates with GABA receptor? Propofol decreases the rate of dissociation of GABA and its receptors. So propofol and barbiturates decrease the rate of dissociation of GABA and its receptors. What is, in contrast, a mechanism of action of benzodiazepines with GABA receptor? I hope you're saying increases the efficacy of coupling between GABA receptor and the chloride ion channel. Increases the efficiency of coupling between GABA receptor and chloride ion channel. So one more time. Benzodiazepines increase efficiency of coupling between GABA receptor and chloride ion channels versus like propofol and barbiturates. They decrease the rate of dissociation. Okay. Barbiturates, just so you know, reversibly depress activity of all excitable tissues. That includes CNS, cardiovascular, and respiratory depression, and there's a renal dysfunction. So they reversibly depress activity of all excitable tissues. That involves CNS, cardiovascular, respiratory depression, causes renal dysfunction. What is the mechanism of action of dexmedetomidine? Well, I hope you're saying inhibition of adenylate cyclase through alpha-2 receptor. It inhibits adenylate cyclase through an alpha-2 receptor. Labetalol. Essentially, what is the mechanism of labetalol? It is a non-selective competitive antagonist of both beta-1 and beta-2 receptors and an alpha-1 receptor. Labetalol is a non-selective competitive antagonist of both beta-1 and beta-2 receptors and then an alpha receptor. What is the ratio of blockade between alpha and beta? Well, I hope you're saying 1:7 IV administration and 1:3 oral administration. So there's more beta blockade. So 1:3 orally and 1:7 IV. Does labetalol exhibit intrinsic sympathetic activity? Yes. Labetalol exhibits sympathetic activity via partial beta-2 agonism and inhibition of norepinephrine reuptake. Labetalol exhibits sympathetic activity via partial beta-2 agonism and inhibition of norepinephrine reuptake. What is the mechanism of action of degradation of labetalol? It is hepatic oxidative biotransformation and glucuronidation. Mechanism of action of degradation of labetalol is hepatic oxidative biotransformation and glucuronidation. What is the effect of cardiac output on labetalol? There's little effect on cardiac output. What happens to SVR? It decreases. What happens to blood flow, renal, cerebral, and coronary blood flow? Renal, cerebral, and coronary blood flow is maintained. It's very important to understand that renal, cerebral, and coronary blood flow is maintained with labetalol. Onset of action of hypertension with labetalol, about 2 to 5 minutes. 2 to 5 minutes for the onset of action. Peak effect, 5 to 15 minutes. Peak effect is 5 to 15 minutes. Effect of labetalol lasts for about 2 to 4 hours. 2 to 4 hours. What is the half-life of labetalol? 6 hours. Labetalol's half-life is 6 hours. Side effects of labetalol: orthostatic hypotension, nausea, dizziness, and fatigue. Orthostatic hypotension, nausea, dizziness, and fatigue. Does meperidine lower threshold even though it's metabolized? Normeperidine is neurotoxic and can cause seizures. Does meperidine lower seizures threshold even though it's metabolite? Normeperidine is neurotoxic and can cause seizures. No, meperidine does not cause seizures. Does tramadol lower seizures threshold? Yes, tramadol has lowers a seizure threshold. What is the effect of pneumothorax on pressure? This is another random one. Pneumothorax increases peak airway pressure. Pneumothorax increases peak airway pressure. All right, clinical characteristics of epidural opioids. What clinical characteristics of the epidural opioids? So abbreviations. We're going to talk about hydrophilic opioids. So what are disadvantages of hydrophilic opioids? Well, I hope you're saying slower onset, longer duration, highest CSF solubility, and extensive CSF spread. There is essentially slower onset of action, longer duration, higher CSF solubility, and extensive CSF spread. Essentially, they have delayed respiratory depression, delayed onset of analgesia, and higher incidence of side effects. So I apologize. The essentially disadvantages of hydrophilic opioids are delayed respiratory depression, delayed onset of analgesia, and higher incidence of side effects. However, the hydrophilic opioids have slower onset, longer duration, higher CSF solubility, and extensive CSF spread. Lipophilic opioids. Their characteristics is faster onset, shorter duration, low CSF solubility, minimal CSF spread, lower incidence of side effects, and rapid analgesia. So lipophilic opioids have faster onset, shorter duration, low CSF solubility, minimal CSF spread, lower incidence of side effects, and rapid analgesia. The disadvantages of lipophilic opioids is systemic absorption, brief single-dose analgesia, limited thoracic analgesia with lumbar administration. So their disadvantages of lipophilic opioids is systemic absorption, brief single-dose analgesia, limited thoracic analgesia with lumbar administration. What drug class is methotrexate? I hope you're saying it's a barbiturate. What barbiturate effect on cerebral blood flow? It decreases cerebral blood flow. What is barbiturate effect on cerebral blood volume? It decreases cerebral blood volume. What is barbiturate effect on intracranial pressure? I hope you're saying barbiturates decrease intracranial pressure. What is the effect of barbiturate on renal and hepatic blood flow? It decreases it. What is important to know about barbiturate mechanism of action that involves the enhancement of inhibitory transmission and inhibition of excitatory neurotransmission? Important to know that barbiturate mechanism of action involves enhancement of inhibitory transmission and inhibition of excitatory neurotransmission. I think we talked about that already. Barbiturates cause CNS depression in what manner? Dose-dependent manner. Barbiturates cause CNS depression in a dose-dependent manner. Do barbiturates cause analgesia? No, they do not. What is the shortest acting benzodiazepine? Well, I hope you're actually saying the reversal agent, flumazenil. It's 45 minutes. In a potential observation, if you give flumazenil, there's a chance for resedation from benzodiazepines. What is the onset of action of flumazenil? It is quick, 1 to 3 minutes, because high proportion of free drug available and little protein binding. The onset of action is very quick, 1 to 3 minutes, because high proportion of free drug available with little protein binding. Where is norepinephrine released from? Well, I hope you're saying postganglionic sympathetic neuron. Norepinephrine is released from postganglionic sympathetic neuron. What channels and affinity does norepinephrine have? It has alpha 1 greater than alpha 2 greater than beta 1. Norepinephrine has affinity for alpha 1 greater than alpha 2 greater than beta 1. What effect does norepinephrine have on hemodynamics? Well, I hope you're saying arterial and venous constriction, which leads to bradycardia. But because there's beta 1 agonism, which increases cardiac contractility and preload from venous system, CO2 is unchanged. So cardiac output. So norepinephrine, essentially arterial and venous constriction, which causes bradycardia, but beta agonism increases contractility, which maintains cardiac output. And so cardiac output is unchanged. Why does cardiac output decrease with phenylephrine? Well, if you think about it, phenylephrine is only alpha 1 agonist without B1 effect. So there's just bradycardia, but there's no increase in contractility, which leads to decrease in cardiac output. All right, so now what we're going to do is go over the channels, over sector activities for the vasoactive agents. And just to correct what I said earlier, phenylephrine actually doesn't have a change to cardiac output. We're going to talk about vasoactive agents, as stated. We're going to talk about its kind of the agent, receptor activity, cardiac output, systemic vascular resistance, its indications, adverse effects. Phenylephrine acts on alpha 1 channel. What is its function on cardiac output? Alright, so phenylephrine acts on alpha 1 receptor. What is its effect on cardiac output? Unchanged. Unchanged. What does phenylephrine act on systemic vascular resistance? It increases. Increases. What are indications for phenylephrine? It's alternate to beta 1 agonist. Adverse effects is bradycardia. And, briefly on all of these, I think, norepinephrine, what is its receptor activity? Well, I hope you're saying alpha 1 greater than beta 1. Norepinephrine receptor activity is alpha 1 greater than beta 1. What is its cardiac output? It's either unchanged or increased. Unchanged or increased. What is the effect on systemic vascular resistance? It's increased. Increased for norepinephrine. What are indications? It's septic shock and cardiogenic shock. Septic shock and cardiogenic shock. And adverse effect for norepinephrine? Tachyarrhythmia. Tachyarrhythmia. Epinephrine, what is its receptor activity? Epinephrine's receptor activity is alpha 1 equals to beta 1 greater than beta 2. So alpha 1 equals to beta 1, and both of those are greater than beta 2. What is the epinephrine's effect on cardiac output? It's increased. What is its effect on systemic vascular resistance? It's typically increased or decreased, actually. What are indications? Well, I hope you're saying anaphylactic shock, bradycardia, cardiogenic shock. Once again, it's anaphylactic shock, bradycardia, cardiogenic shock. Epinephrine's adverse effects are tachyarrhythmia and splanchnic vasoconstriction. Tachyarrhythmia and splanchnic vasoconstriction. Let's talk about dopamine. So dopamine has low, medium, and high receptor activity, right? So low, medium, and high receptor activity. So what is its, at low doses, what is the dopamine's receptor activity? Well, I hope you're saying it's dopamine greater than beta 1. Dopamine's greater than beta 1. Its effect on cardiac output at that point is increased, and systemic vascular resistance is unchanged. Now, if we go to medium dose dopamine, what is its receptor activity? So dopamine now is equal to beta 1, and together they're greater than alpha 1. Dopamine at medium dose is equal to is equal to beta 1 greater than alpha 1. Cardiac output is increased, and so is systemic vascular resistance is also increased. Now, at high doses, what happens to dopamine receptor activity? Beta 1 is greater than dopamine, which is equal to alpha 1. So at high, beta 1 predominates. It's greater than dopamine, which is equivalent to alpha 1. So the cardiac output is increased, and systemic vascular resistance is greatly increased. So what are indications? So relative or absolute bradycardia at low risk for tachyarrhythmias. So dopamine is indicated at relative or absolute bradycardia and low risk for tachyarrhythmias. What are adverse effects? High rate of tachyarrhythmia. High rate of tachyarrhythmia. Dobutamine. What is dobutamine's receptor activity? Well, I hope you're saying beta 1 greater than beta 2. Dobutamine's receptor activity is beta 1 greater than beta 2. What is dobutamine's effect on cardiac output? It's increased. Increased. What is the effect on systemic vascular resistance? Dobutamine decreases systemic vascular resistance. What is the indication for dobutamine? It's cardiogenic shock. Cardiogenic shock. What are the adverse effects for dobutamine? Tachyarrhythmias and hypotension. Tachyarrhythmias and hypotension. Vasopressin. What receptor does vasopressin act on? Well, I hope you're saying it is V12. V12 receptor. What is the effect of vasopressin on cardiac output? Unchanged. Cardiac output is unchanged. What is the effect on systemic vascular resistance? Well, I hope you're saying it's increased. It's increased. What is the indication for vasopressin? It is second line for septic shock, may reduce atrial fibrillation. It is second line for septic shock, and it may reduce atrial fibrillation. What is the adverse effect of vasopressin? I hope you're saying mesenteric ischemia at high doses. Mesenteric ischemia at higher doses. Angiotensin II. what receptor activity does angiotensin 2 act on? Well, I hope you're saying AT1. Angiotensin 1. So AT1. What does angiotensin 2 affect on cardiac output? It has no effect on cardiac output. No effect on cardiac output. What does angiotensin 2 receptor activity have on systemic vascular resistance? It increases systemic vascular resistance. What is the indication for angiotensin 2 treatment? It's a refractory septic shock. Refractory septic shock. What is the adverse effect? It's actually thrombosis. Thrombosis. All right, methylene blue. What is the receptor activity for methylene blue? It inhibits nitric oxide synthase and SGC. Inhibits nitric oxide synthase and SGC. What is methylene blue effect on cardiac output? It has no effect on cardiac output. What is the effect of methylene blue in systemic vascular resistance? It increases systemic vascular resistance. What is it with the indications? So refractory vasoplegia. Refractory vasoplegia. What are the adverse effects for methylene blue? I hope you're saying hemolysis, serotonin syndrome. Hemolysis and serotonin syndrome. That concludes the specific channel components. Now more to questions. Where does dexmedetomidine produce its alpha-2 sedative hypnotic effect? Where does dexmedetomidine produce its alpha-2 sedative hypnotic effect? I hope you're saying locus coeruleus, which decreases histamine release from tuberomammillary bodies, which results in sleep state. So dexmedetomidine produces its effects in locus coeruleus that decreases histamine release from tuberomammillary bodies, which produces sleep state. Where does dexmedetomidine produce its alpha-2 analgesic effect? I hope you're saying dorsal horn. Dorsal horn. All right, so now we're going to talk about what interferes with acetylcholine release. So factors that decrease release of acetylcholine. I hope you're saying for antibiotics, it's clindamycin and polymyxin. Clindamycin and polymyxin decrease acetylcholine release. Magnesium, which antagonizes calcium. Hypocalcemia, anticonvulsants, diuretics, furosemide, Eden-Lambert syndrome, which inhibits B-type calcium channels, and botulinum toxin, which inhibits SNARE proteins. So once again, what decreases acetylcholine? Well, I hope you're saying for antibiotics, it's clindamycin and polymyxin. Magnesium, hypocalcemia, anticonvulsants, diuretics, furosemide, Eden-Lambert syndrome, which inhibits B-type calcium channels, P-type calcium channels, botulinum toxin, which inhibits SNARE protein, and magnesium again antagonizes calcium. Do calcium channel blockers such as nifedipine or diltiazem have decreased release of acetylcholine? They do not affect acetylcholine because they do not affect B channels. They do not. So the calcium channel blockers, nifedipine and diltiazem, affect L-type calcium channels. L-type calcium channels. What is the mechanism of drug metabolism called? What is the mechanism of drug metabolism called? I hope you're saying biotransformation. And biotransformation is an example of CP450 enzyme system. When lowering nitrous oxide, what can be done to decrease risk of diffusion hypoxia? Well, I hope you're saying administering 100% oxygen. In order to decrease the risk of diffusion hypoxia, you administer 100% oxygen. Opioids like ramifentanil induce hyperalgesia can be prevented or reduced via co-administration of which drug? So opioids like ramifentanil induced hyperalgesia. How do you prevent the what other drug do you give? So you give NMDA antagonists like ketamine, butrafenol, buprenorphine, and nitrous oxide. So NMDA antagonists like ketamine, butrafenol, buprenorphine, and nitrous oxide prevent opioid-induced hyperalgesia, like in the instances of ramifentanil. What is the Meyer-Overton correlation? Meyer-Overton correlation is the linear relationship between anesthetic potency and solubility in olive oil. It is a linear relationship between anesthetic potency and solubility in olive oil. What is the current theory? The current theory is the protein target-based theories. Mannitol functions similar to ANP from the heart or hyperglycemia. I hope you're saying hyperglycemia. Hyperglycemia and mannitol are osmotic agents, where ANP just simply dumps out sodium in the collecting duct rather than like the main compartment of the body, right? If the patient doesn't want a block for weakness or opioid, if a patient doesn't want a lower extremity block for knee arthroplasty, if they don't want opioids, can they receive a local anesthetic only for knee arthroplasty? Yes, they can after discussion with the surgeon. What are the layers of the nerve anatomy? Well, I hope you're saying epineurium, perineurium, and then endoneurium. So the way that it works is multiple endoneuriums wrap axons to form fascicles. So multiple endoneuriums wrap axons to form fascicles. These fascicle is then wrapped by perineurium, and then epineurium wraps these perineurial, so to speak, fascicles. So multiple endoneurium wraps axons to form fascicles. Fascicles are then encased in perineuriums, and then these perineurial-like fascicles are wrapped by epineurium. Where is most a local anesthetic administered? So it's outside of epineurium. What is the extrafascicular block? It's a epineurial injection. What is the intrafascicular block? It is subepineurial injection. So extrafascicular is epineurial injection, infrafascicular is subepineurial injection. Which local anesthetic does not cross placenta? Well, I hope you're saying 2-chloroprocaine. 2-chloroprocaine. Why doesn't it cross the placenta? Well, because it gets broken down by plasma chloresterase in the serum in like 12 seconds. So it's broken down too fast. Is it safe in pregnancy or cesarean delivery? Yes, it is safe in pregnancy and cesarean delivery. And just of note for local anesthetics, ester local anesthetics undergo breakdown by plasma chloresterase, while amide local anesthetics undergo hepatic metabolism. So ester local anesthetics undergo breakdown by plasma chloresterase, while amide undergo hepatic metabolism.